Thank you for the introduction. So like Dr. Ayler mentioned, I'm going to be discussing dual therapy and gram-positive infections. So today's learning objectives will be to summarize the pharmacokinetic and dynamic rationale behind dual therapy, evaluate some opportunities when it's seen for dual therapy, and then also to propose an antibiotic regimen given a patient case. I have no disclosures, no conflicts of interest, and we'll be discussing some non-FDA approved indications for antimicrobial therapy. So I think we're all familiar with this list. This is the CDC prioritization list of drug-resistant organisms. But I think when we look at this list that we normally concentrate on what would be the gram-negative infections, which are listed in priority 1. So our CRAB, or carbapenem-resistant Acinetobacter, or MDR Pseudomonas, and then also our carbapenem-resistant Enterobacter ACA. So if you look at the numbers, there's about 250,000 infections per year, which results in about 14,000 deaths. So taking that into account, when you actually go down to our their priority 2 or their high priority burden of drug resistance, you can actually see with vancomycin resistant Enterococcus and with methicillin resistant Staph aureus, there's actually almost double the amount of infections and even a significant more amount of deaths. These numbers have changed looking back when I updated my slides from 2013 to 2019. A lot of this is correlated with potentially some infection prevention manners and some other things, but we can still see that that gram-positive still can carry a significant amount of burden of infections overall and a significant amount of deaths. To go along with that, what we're also more familiarized with in targeting these gram-negative infections is the abundance of gram-negative agents approved since 2008 compared to gram-positive. And this is just a simple table where you can tell that really ceftriaxone and kind of dalbavancin or ridavancin they're not even necessarily new. You could say that ceftriaxone is a new agent since then. We know that dalbavancin or ridavancin kind of mimic previously vancomycin, just longer acting, and then obviously today's lids in coordinates with linezolid. So really, once you take all these away, you're left just with ceftriaxone. And you can see as we have introduced our antimicrobial agents, we have started to develop resistance. So early on, vancomycin was used in the early 70s. Within a 15 to 20 year span, we ended up having vancomycin resistant Enterococcus. Then we had the introduction of linezolid, and then we have linezolid resistant Staphylococcus. And you can see how this trend just continues as newer agents get developed. These gram-positive organisms develop this resistance very rapidly. So some things to consider for combination therapy are what are the risks and benefits? Do we have an additive effect here? Do we have a synergistic effect from an in vitro standpoint? Do we have improved outcomes, or do we have a higher kill rate? Do we need biofilm penetration? And then also, do the benefits actually outweigh the risk associated with combination therapy? We know that if we use 2 beta-lactams, we might have a higher propensity for lowering a seizure threshold and thus having that as a side effect. We know that neutropenia is a problem with some beta-lactams. And then also, will this cause, increase in antimicrobial resistance? And then also, is there data that lets us know is one combination better than another one, or is it more of a situation-dependent scenario? So what I'll first start out with is going to be to clinically address, or the two things I'm going to clinically address are MRSA and then Enterococcus species, particularly focusing on faecalis and faecium. To start out with, we're going to jump right into MRSA. So to give you a brief patient case, CMI is a 45-year-old male with a past medical history of IVDU. He presents with an infectious-like picture. He has a blood culture that shows Staph aureus, further identification pending. So he's diagnosed with a Staph aureus bloodstream infection, likely from his IVDU history. So what do we know about MRSA? We know that it's asymptomatically carried by about 10 to 40% of individuals, even up to 50% in some numbers. It has multiple virulent factors from toxins to enzymes and biofilm creation. We do know that methicillin-resistant Staph aureus does create a higher mortality, up to 50%, that ranges from 25 to 50, than MSSA. And we do know that individuals infected or colonized are actually at a greater risk of developing decreased susceptibility to vancomycin with prior usage. So even if somebody's colonized with MRSA and we give them vancomycin, say, for and ammonia because we're presuming based upon that MRSA NARS, they have a higher propensity to actually develop resistance along the way. So when we look at the structure of how Staph aureus becomes methicillin resistant, it really has to generate around acquiring the expression of MEK-A, which is a genetically mutated PBP2A penicillin binding protein. So that's what confers the inability of our or when it has the SEC-MEK or the MEK-A gene mutation, it actually prevents our beta-lactam antibiotics from binding that area. So it reduces susceptibility for those, and thus you end up having vancomycin being able to target the molecule at this point in time for being a more ideal drug. So things to consider, why we would consider combination therapy for Staph aureus bacteremia. One, it does carry a high mortality rate. The second point is source control versus persistent bacteremia. And we do know in some of the cases that we will be unable to get source control. Some of our IBD drug users that have endocarditis, some patients with osteomyelitis unwilling to have removal of the joint and or bone or area that has the infection. Sometimes that we actually can't find the actual source. So with persistent bacteremias and with persistent source control, we will have these potential increased metastatic complications, increased length of stay in the hospital, and some would consider potentially an increased mortality. There has been some studies that does show persistent bacteremia as an independent predictor of 30-day mortality, but it actually can vary what some people say. Some people associate 3 days, 5 days, 7 days. That number's really to be conferred by kind of clinical expertise. I tend to go with 5 days personally, but I know some go with 3 and 7. Obviously, the source of infection, so a high burden source, we want to consider combination therapy, just needing to get that burden of infection down. And then does the data lean or favor MRSA versus MSSA? Do we know if combination therapy for one of these is better than the other one? If you look at the data now and that we're going to get into, really combination therapy is focused on MRSA, just because with MSSA you still have your anti-Staphylococcus beta-lactams and also your first generation cephalosporins that have shown non-inferiority to each other and are able to be readily used. So two of the combinations I'm going to be discussing are vancomycin plus a beta-lactam and daptomycin plus a beta-lactam. First, we'll jump into vanc and a beta-lactam itself. So to start out with, we'll get a little bit into reviewing the pharmacokinetics and dynamics. I know plenty of us pharmacists have heard this dozens of times, and I think even physicians are probably tired of hearing about vanc kinetics. The drug has been around for 40 years at this point in time, and we still debate exactly how to dose it. So we do know that it does follow a AUC, MIC type distribution as far as from a PK standpoint. We know that this 400 to 600 range shows a clinical safety, not so much an advantage efficacious-wise, but a clinical safety standpoint. That this drug has a very high volume of distribution. So when you have a heavy amount of adipose tissue, high BMI, it's definitely going to fill those areas up first. And then as you can give more and more doses, there'll be a point in time where you have an equilibrium, and we'll use the terminology, the vanc will spill out, or it'll be able to distribute out of those tissues. It does get unexcreted unchanged in the kidney. So this is why we have to be monitoring, what goes on kidney-wise. But if we do have any infection within that area, we obviously can give relatively low doses. So what happens when you actually use a vancomycin against MRSA, and what it actually does the Staph aureus in itself do to try to defend itself or put up a barrier protection? So we know that vancomycin targets the D-alanine portion of peptide side chains, and it actually binds the D-terminal alanine residues of lipid 2 and prevents transglycosylation and peptidation by PBP2 and PBP2A. So a small little example is kind of shown on the screen where it actually binds in within the cell wall. So what happens is with prolonged treatment or reintroduction of treatment, you will get particular strains that have required several genetic chromosomal mutations. So it'll mainly direct these genes, or these mutations will mainly happen within the cell wall, within biosynthesis and the homeostasis of the cell wall. So as you continue to give vancomycin, you actually have the Staph aureus in itself will actually increase in thickness and the architecture of its cell wall. So what ends up ultimately happening is you have variability in the cell wall structure, while you also have an increase in the number of free dealanine residues. So this is how you have your quote-unquote MIC creep, is the terminology that you'll hear some use. This will also lead to what potentially can be your vancomycin intermediate Staph aureus, and then also we know as your vancomycin resistant Staph aureus. So by doing these two measures, you really prevent vancomycin from getting in that cell wall. So you have this greater, thicker architecture of the wall, more binding sites, thus the MIC creeps up. So what happens when you actually have, this is another example of it showing just from a more focused standpoint. So you can see on the left-hand side, you have a vanc-sensitive molecule, so it's actually able to get all the dealanine residues with, and also very well readily diffuse across the septum. When you actually have vancomycin resistance, it increases that cell wall architecture, as we can see here, and also increases the number of residues that needed to be bound. So you can see from a different standpoint that the actual cell wall in itself does increase quite significantly. So what happens when we add a beta-lactam? We have something called the seesaw effect. So it's a proposed mechanism of a vancomycin plus a beta-lactam that will ultimately try to accomplish a combination of several different things, essentially relating to more effectiveness of your usage of your vancomycin. So first, with beta-lactam exposure, we will see a decrease in the expression of penicillin binding proteins. This will in turn decrease the thickness or the architecture of the cell wall back to its normal expression. It'll also disrupt the function of these PBPs, kind of leading to the same cause. And then by doing all this, once again, you just have that really importance of reducing the thickness of that cell wall. But as we were talking and discussing about earlier, this is methicillin-resistant Staph aureus. So how exactly is a beta-lactam, in this case, becoming or helping or aiding vancomycin? Well, it has to kind of do with a fine fluctuation of how MRSA is able to withstand actually the expression of vancomycin, or what it does in the presence of vancomycin. So but once vancomycin is introduced to MRSA, you end up having these loosely linked and thickened cell walls that we discussed. Well, because of that, you actually end up having a reduction of your PBP4 and or PBP2A, which is what actually drives or does the synthesis for some of this production in peptidoglycan translocation. So it's actually been shown that PBP2A is really essential for bacterial growth and transpeptidase and also transglycase. PBP4A has some role in that, but really PBP2 is the heavy component of those two that stretches it. So when you have this fluctuation and you have this reduction of PBP2A, you end up getting this increase in this PBP2 to drive wall cell assembly. So that's what's increasing your cell wall thickness. So in order for it to increase the cell wall thickness, and then also increase the amount of dealanine substrates, it has to actually increase a certain PBP in itself. So from an overall standpoint, strains exposed to beta-lactams targeting PBP2 become more susceptible to vancomycin, because beta-lactams are able to target PBP2, and we know that it's able to drive down the actual cell wall thickness, as we described earlier with the events. This has been shown through this is a light number, it's probably more than 20 at least at this point in time, in vitro studies exploring this combination. We know that the majority have found synergy in some or at least all strains. There can be some variability between vanc-sensitive Staph aureus, vanc intermediate Staph aureus, and vanc resistant, and heterogeneous vanc intermediate Staph aureus when you kind of look at some of the in vitro data. But to put it in a very quick perspective, one of the easiest studies to look at is what Tran and colleagues did. They were able to look at several different common beta-lactams that are used, so cefazolin, cefepime, ceftaroline, and nafcillin. They took this and they looked at it in a 24-hour period and were able to see a synergistic bactericidal benefit of adding that on to vancomycin. So here, looking at the vanc-sensitive Staph aureus, you can see with no combination, its E-test was 1. And then as you are able to add a beta-lactam agent, more specifically looking at cefazolin and ceftriaxone, you actually get significant between a 4 to 16-fold reduction overall in your MIC. So making it more susceptible to vancomycin at this point in time by adding on that beta-lactam. Again, looking at heterogeneous vanc intermediate Staph aureus, you get the same type of effect. By comparing the two, you can see there's a little bit of variability by how the beta-lactams in themselves lower the degree of the MIC for vancomycin, but from overall standpoint, you can really tell that cefazolin and ceftriaxone are having the most activity, while cefepime and nafso in this case have some reduction, but it can be variable between the different isolates. And then looking at vanc intermediate Staph aureus, you can see once again that MIC of 4 and that significant, 4 to 16-fold increase by adding on a beta-lactam therapy. So what clinical data do we actually have to support this? Obviously, we all enjoy in vitro data, but what does it mean for clinicians and how it is going to affect our patients? So as far as clinical data, the stuff that came out most recently was all retrospective within a way, and then we have one RCT, randomized controlled trial, that came after that. So looking at some of the earlier data, Casino and colleagues did vancomycin plus a beta-lactam for at least 48 hours. While clinical failure, there was a percentage difference, or what we would say from a statistically significant difference. There was nothing there, but it did improve the rate of microbiological clearance, which was statistically significant by 1 full day. So going back to what we know earlier about the data that was shared, that having this persistent bacteremia can please or increase your odds ratio of having mortality. So does that improved rate of microbiological clearance in this case going to translate out to that? And then early on, camera 1 was done by Davis and colleagues. They looked at vancomycin plus flucloxacillin. The reason for this specific beta-lactam was because it was done in a different country. So this was a pilot study to facilitate a bigger randomized controlled trial. Once again, they were able to show a decreased duration of bacteremia by 1 full day, and there was some potential increase for renal toxicity at this point between vancomycin and flucloxacillin, but nothing that significantly stood out that would prevent this from progressing to a randomized controlled trial. So then came about camera 2, which was the backbone or the build-off of the pilot study of camera 1. So Tung and colleagues sought to see vancomycin or daptomycin plus an anti-staphylococcal beta-lactam, which they included flucloxacillin, cloxacillin, and cefazolin for 7 days for MRSA bacteremia. This was a multi-center randomized controlled trial. The way they dosed the vanc and the dapto, they did vanc trough levels of 15 to 20, and they did dapto dosing 6 to 10. Because of the sites where they were, about 99% of the patients mostly received vancomycin. So looking overall standpoint, you can, looking at monotherapy on the left-hand side and combination therapy on the right-hand side, you can see their composite endpoint did not meet any statistical significance, but bacteremia at day 5, you can see that the combination therapy had about a 9% risk reduction overall in clearance of bacteremia. And then the bigger data that a lot of people focused on was AKI. So within the combination group, there was about a 17% difference between the two, favoring the combination to having more likely to cause AKI. This was something that has been addressed several times at conferences, and I know is of peak interest to a lot of clinicians and hesitation about using beta-lactam or using dual therapy, particularly a beta-lactam with vancomycin. But to really understand where this AKI is coming from, you kind of have to dive deeper into the data. So when you look at actually the post-hoc analysis that they did, the significant majority of the patients, so out of a total of 31 patients that did experience an AKI, 30 of them were on vanc plus flucloxacillin or cloxacillin, so the typical anti-staphylococcal beta-lactam, not what we associate with being just your first generation cephalosporin. There's only one within the cefazolin group. So that really raised some eyebrows that if you're going to proceed with combination therapy, that favoring using cefazolin or a cephalosporin over our traditional anti-staphylococcal beta-lactams is more wise as far as an AKI standpoint. So in conclusion, they end up stating that adding a beta-lactam to standard care didn't statistically benefit on a composite endpoint of death. However, you did get a decreased bacteremia at day 5, but subsequently you did have an increased risk of AKI, with that post-hoc analysis exploring that it was more specifically related to the anti-staphylococcal beta-lactam. Some limitations, these are what I derived from the study. So it was VANC trough-based dosing. We do know from the PK/PD of VANC that AUC dosing is an improved safety. And when you really get into that study, I took the supplementary and some of the other components, additional materials of it, and really got into the VANC levels that they were dosing at and what their patients looked like. And there is some concern from my point of maybe not only did they have a higher risk of AKI because of they were using trough-based dosing, but they were also using a trough-based dosing that was really aggressive. If you look at their median troughs at day 3, I think 17 to 18 is kind of where most of them are, which is, we know as you can use your trough with some estimation of pharmacokinetic parameters and extrapolate out to an AUC, and that would put them at a higher risk just having that elevated trough level. And then also, some of the findings may have been confounded by the high rates of AKI. So if the patients maybe didn't experience an AKI, could they have had a mortality benefit or greater benefit? And then about 40% of the patients would be defined as a low risk group. So when I say low risk, this would be evaluating, would this patient be an ideal candidate for dual therapy? So would they have a high burden infection? So about 40% of the patients in the study had a skin and soft tissue or IV/central line source of bloodstream infection, which I believe we would all be in consensus here that those would be defined as a low risk group. So implications that I got from it, don't use VANC plus leucoxycillin or cloxacillin, or in our case would be nafcillin or oxacillin because of the toxicity. VANC plus NSAID still has a potential benefit, particularly in the high risk groups. So these would be your endocarditis, your osteomyelitis, your epidural abscess, anything within that kind of realm of it. And that we still obviously need to explore some more trials. We can't just, knowing that post-hoc analysis can't solely harp upon its results to dictate how we should proceed forward. So pros of adding on a beta-lactam to vancomycin is the seesaw effect that we discussed. You can use lower troughs and lower AUCs, which would theoretically should lend to less nephrotoxicity, but you do have the con side, which looks at there has been some data to support that you do have an increased risk of AKI, though it might be drug specific. There's controversy over whether decreased duration of bacteremia and controversy over VANC MICs from an overall standpoint. Some will argue, that if you have a VANC MIC 2, that you should add on a beta-lactam agent in this case, but you can still have clearance. It's just obviously at its higher break point. And then the con to the decreased duration of bacteremia is there's no direct mortality benefit. So my major takeaway, especially particularly the fellows, would be that in high-risk groups, so people that are non-SSTI or non-line-related sources, the need for combination therapy should be considered upfront. So going back to our patient, a CM or IBD drug user that presented with Staph aureus bacteremia, which of the following empiric regimens would be most appropriate for this patient? Anybody can be free to comment out what they would do or to put it within the chat.
Vancomycin.
Yeah, that's exactly what I would go with as well. I would do vancomycin, particularly in this case, because it is someone that we would consider a high-risk patient with a history of IBD use. So not having or not knowing it's coming from a line, they're maybe more likely to have endocarditis and needing that dual therapy in this case to help get that clearance up front, and then to be determined if it does actually provide a overall mortality benefit. So the next combination we'll hop to is dapto plus a beta-lactam, which I know this has been a little bit more prominent of evidence as of late, in particularly one particular beta-lactam. So looking at the daptomycin PK/PD, you can always kind of remember go big or go home. So it has a kind of two-pronged way of looking at its pharmacokinetic diameter. So it actually has a peak MIC and AUC over MIC that potentiates asexual killing. So when you actually extrapolate that out, you can see as you give a higher mg per kg dose, you get a higher Cmax, and you also get a higher AUC. Thus, you get that higher ratio and higher kill log than you would, and faster kill log than you would with lower doses. So we do know that it's about 90 to 93% protein bound. So you can have some issues in patients that have albumin issues or patients that are in septic shock. Like we mentioned, the higher doses does have that increased activity. And then with Staph aureus, ideally to elicit a 1 kill log ratio from an in vitro standpoint, you need to have an AUC of MIC ratio of 666. So that's kind of why more lately about has come to use the higher dosing for Staph aureus instead of the package insert that says to use 6 mg per kg. We advocate to use that 8 to 10 mg per kg. So as far as its mechanism, so if you talk to Dr. Hanley, and I would agree with him the same way, we really don't know the mechanism of daptomycin. There's been several different proponents that have been suggested of how it works. The mechanism we're all probably most familiar with is that it complexes with calcium ions within the cell wall, or oligomers with outside the cell wall that help to essentially create a negatively charged phospholipid head, and this depolarizes the cell, causing a leaking of ions and ultimately cell death. So it kind of acts like a cationic peptide, is attracted to a negative charge within the cell wall. So if you think about that it's a cationic peptide and then it wants to go to a negatively cell wall, how is a bacteria going to formulate a resistance to get that? Well, relatively easily. With prolonged exposure, you get an increase in bacterial membrane positive surface charge. So something called MPRF mutation that we're associated with for its most likely development for resistance. And then also it creates some alterations in the bacterial membrane fluidity. So with prolonged exposure, you do have this increase in amount of positive charges. So you either have to find a way to give more drug, which could eventually lead to toxicities, or find a way to cause the polarization of that membrane to go back to its to more negative state, so daptomycin can have more binding areas. So that's what comes along when we add in our beta-lactam. So once again, you have this terminology called the seesaw effect. So when you're able to give a beta-lactam, you have a increase in the net negative surface negativity and a decrease in the positive surfativity, like we were talking about. So getting back to that neutral state or almost negative state of the cell wall, allowing more daptomycin to bind. Then we get that enhanced daptomycin binding for what it is. So overall, you do get a more negative net charge. This can be seen and well documented with various beta-lactams. We'll discuss more specifically into ceftriaxone and ceftriaxone, cefazolin, and those. So to get really into the mechanistics of how this occurs, so when daptomycin is exposed to Staph aureus, what Staph aureus does is it induces a cell membrane polarization and reduced cell wall thickness, causing that alterations and functions of important proteins in the cell wall structure. So you get that overall more positive charge. What it specifically does, it has an increase in septation in sites of division through PBPA. So what happens is to create that polarization of the wall, it actually has to increase PBP1, which PBPA is kind of a substrate for PBP1 activity within cell wall division. So going back and referring to what our PBP2, so we know for PBP2 within Staph aureus, it actually helps with the cell wall texture and the translocation and transpeptidation that help the de-alanine aspects within that. So with daptomycin, we're looking more towards PBP1, which there's a little bit about, but it's most strongly associated with daptomycin potentiation because of how it's able to be a compensatory mechanism with exposure to daptomycin through increasing its substrate or PBPA cell wall division. So it's really that primary driver for cell wall division rather than the peptidoglycan biosynthesis per se. So from an overall standpoint, PBP1 blockade is the strongly most associated with daptomycin potentiation of activity. So beta-lactams with affinity for PBP1 enhance the anti-MRSA activity of daptomycin, and then beta-lactams that actually target PBP1 and 2 give the most potent effect from an overall standpoint. And we can see the reasons we are able to clearly define that is looking really at the in vitro data to know which one binds PBP2 and PBP1 better. So from an overall standpoint, these are a growth control plate with colony forms looking at a colony forming units on the left-hand side, and on the bottom as time 0 to 72 hours. And so this is really one of the more nuanced that showed how well daptomycin does with ceftriaxone when compared to other combinations. So you can see this purple line represents and the increased dosage that we talked about earlier that we had been pushing for daptomycin. And this actual blue line right here actually represents ceftriaxone at 600 Q8. But what's actually extremely interesting is when you put those two together, you get this dramatic kill log very quickly off the beginning that's actually sustained at a lot lower concentration for a longer period of time than when you see with the other combinations or other potential single agents. So this really is what kind of jump-started the daptomycin plus ceftriaxone in this case may be able to have better activity because of this. So the reason for this is what we referred to earlier. Ceftriaxone does have that enhanced binding to PBP2 through its mechanism, particularly PBP2A. It's able to get into that deep cleft that the other beta-lactams aren't able to get into. And then it also has that PBP1 binding. So what we learned from an in vitro standpoint is that it really enhances dapto activity by reducing cell wall thickness, but then also it does create some biofilm, anti-biofilm properties that you would think about with like a rifampin, in particularly, not so much associated with the beta-lactam. So getting more specific down to beta-lactams, because from a standpoint, we don't always are going to jump to our dapto ceftriaxone. You can see that beta-lactams with affinity for PBP1, example, cefazolin and meropenem, have a lot more enhancement of daptomycin's activity than just the other agents. And you can see here just a simple kill log ratio time again. Cefazolin has that greater time, and so does meropenem when compared to cefoxitin and ceftriaxone. So from a clinical data standpoint, we have several retrospective studies that showed daptomycin plus a beta-lactam did, sorry, this is a case report, beta-lactam plus daptomycin did show a potential endovascular source successful outcome in a persistent source. And then really jumping into when that data released about daptomycin ceftriaxone, we started to see more case series and more retrospectives at that point in time. The most prominent one being Mercuri and colleagues. They did daptomycin versus ceftriaxone versus standard of care. Within that, we were able to see an actual 30-day mortality benefit for the daptomycin plus ceftriaxone. The study does have its nuances and issues, but I'm not going to delve into those. It just more or less gave us the idea that, hey, maybe this actual combination does offer a potential mortality benefit. Fast forward a few years, Jorgensen and colleagues did a retrospective study at this point in time of dapto plus a beta-lactam for at least 24 hours, not particularly focusing on ceftriaxone. And they were able to show that your 60-day mortality and reoccurrence when using a dapto plus a beta-lactam, you did have an adjusted odds ratio that showed that favored combination therapy when compared just to dapto alone. But once again, you did have this acute kidney injury come about with the beta-lactam on there. So when they were actually looking at combination therapies, they did not limit it just to our traditional anti-staphylococcal beta-lactams or first-gen cephalosporin beta-lactam. They included all beta-lactams in there. So we do know that that has some issues that needed to be explored, but never really got into a post-hoc analysis. So implications from their study, it did continue to open that door for a randomized controlled trial to look at dapto plus a beta-lactam, because we were seeing these improved patient outcomes persistently within our retrospective data. This ended up being the consequence of that. Garrick and colleagues, they looked at dapto plus ceftriaxone within 72 hours versus standard of care monotherapy. This was a randomized prospective open label trial with computer generated assignment. Everybody had an ID console at the time. Their main outcomes were duration of bacteremia and in hospital patient mortality, while also looking at 60 and 90-day mortality. Extrapolating out what they were able to find. So when you compared the combination to the monotherapy, as far as mortality, there looked to be superiority clearly with the combination therapy from a numbers basis. And then once you even looked at bacteremia length of stay, those did not show any statistically significant data, but the main thing that harping on was the data supporting a mortality benefit with the combination therapy. So take home point just is that standard therapy showed a significant risk of mortality compared to combination. So from their conclusions, they concluded that this combination therapy could reduce inpatient hospital mortality compared to your standard treatment. There were some significant limitations. This trial was actually stopped short. It was stopped short by the review committee that was oversighting the trial. When you really kind of get into looking, at trials that do stop short, there can be an exaggeration of early benefits because there's only about 40 people within this study. And what was also interesting with this study is there was no predefined rule for stopping. So inherently, it was stopped just because of the percentages they were seeing. And then the small cohort, there were some inconsistent source control measures, and these results really haven't been seen before in previous studies with Staph aureus. We haven't ever seen a Staph aureus study with 0% mortality, which is what this one was showing. So implications, so when a patient with severe endovascular infection, unable to clear their therapy, or maybe if they're up front, they're extremely high risk, consideration of ceftriaxone to your standard of care may be warranted. So once again, kind of going through the pros and cons, they end up lining the exact same as adding on a beta-lactam to daptomycin. So getting to our case again, we actually started CM on zinc plus cefazolin. He's had blood cultures that have been persistently positive for 7 days. We started to notice physical signs of what would be potentially endocarditis. He did develop an AKI, and he did get diagnosed with MRSA endocarditis with septic emboli, and acute care surgery is saying he's not a surgical candidate. So in this case, which of the following antibiotic plans would be most appropriate? If anybody feels to they can unmute their mic and say what they would like to do. Yeah, at this point in time, it would seem that this patient would most benefit from dapto-ceftriaxone. So getting to the major takeaway points for combination therapy for MRSA, high-risk groups, the need for combination therapy should be considered. Some of the newer papers utilize an IL-10. I know that's a risk stratification marker to see who would be higher risk. I know that's not readily available at all places, but something to consider if you do have it. I would avoid combination therapy with anti-Staphylococcal beta-lactams, and I would try to initiate combination therapy within the first 72 hours, ideally 24, particularly if there's issues with source control and the clearance of bacteremia, or essentially there's issues with source control. And then to determine the duration of time for combination therapy, really source control and clearance of bacteremia can dictate that. The institution that I previously came from before going to Moffitt, our actual standard of care when Staph aureus was identified in a bloodstream was to start Vanc and Cef up front. So now transitioning to our other bug of interest is Enterococcus. I think a lot of people think of Enterococcus as just kind of a giant nuance. It's typically associated with every intra-abdominal abscess you ever see, and who knows if it's actually being a virulent organism or if it's just hanging out. But it does have multiple virulent factors, just like MRSA, which is toxins and biofilms. It can sustain for an extremely long period of time on surfaces, so hand hygiene is an extremely important way to have a decrease in these amount of infections. It does create a high mortality if you do end up getting a severe infection with it. And broad spectrum on multiple courses of antibiotics do increase your colonization of Enterococcus. You can think about it, not too many of our broad spectrum antibiotics really target Enterococcus, and a lot of them target our gut flora. Thus, we get an increase in the amount of Enterococcus within our GI system. Of the most clinically relevant species are faecalis and faecium. We know that we more often see faecalis, and it's more virulent and with the majority sensitive to ampicillin. And then faecium tends to be less virulent, but the majority of it is resistant to ampicillin and vancomycin. We know that vanc resistance with with faecium is associated with higher mortality, longer length of stay, and higher direct medical costs. So the way Enterococcus becomes resistant to particular antibiotics, in this case, we'll focus on the beta-lactams, is that it has an increase in what is called PUP5 within its cell wall system. So beta-lactams do not have a great ability to bind to that. They have a reduced binding affinity. So it actually increases more so an overproduction of that, which facilitates ampicillin resistance. And then if you look at some of the other mechanisms, you can see around that it has a wide variety of that is able to apply towards different variations of antibiotics. So two potential scenarios we'll be looking at is E. faecalis endovascular infection, so whether you to use AMP or Gent or AMP for Ceftriaxone. And then for Enterococcus faecium, looking at daptomycin plus the beta-lactam, and also looking at some newer data that just actually came out about a month ago. I forgot to update this slide, sorry. I have my introduction slide updated, but also phosphomycin plus daptomycin. So to jump right into it, E. faecalis. So we have a JW, a 80-year-old with a past history of myocardiopathy, status post of mitral valve replacement. He ends up presenting with a Enterococcus faecalis, a bloodstream infection, and has a 5mm vegetation noted on his mitral valve. So in this case, what would be the most appropriate combination to start out with, and would even combination therapy be appropriate in this case? So from previous literature, we cited that ampicillin has what they would say a lack of bactericidal activity against Enterococcus, and that Enterococcus does have a really high ability to form biofilms. So what they mean by lacks bactericidal activity is that when you put it within a petri dish and you look at the kill forming units, you have less than 99% of your colony forming units killed within a 24-hour period. It's actually 90 to 99%. Comparatively, if something that's cytal, you have greater than 99%. And then also with a consideration we need to for E. faecalis is our source of infection. So getting right into it, we'll take a look at AMP and Gent first. AMP, like we had stated earlier, to really get that, is mostly classified as bacteriostatic versus Enterococcus. To really get that bactericidal effect, we have to give a tremendous amount of dosage over a persistent long period of time. And just from its pharmacokinetics, it doesn't readily work out that well. So how did we get the idea to use an aminoglycoside for synergy for Enterococcus? Well, taking a step back and getting to more the in vitro side of things, we know that the majority of Enterococcus have a really low level of resistance to aminoglycosides, mainly because the aminoglycoside can't get through the cell wall. So when you're able to give a cell wall inhibitor with an aminoglycoside, it actually facilitates its uptake and overcomes that small intrinsic resistance. So when looking at in vitro studies, this combination was shown to be synergistic, but there are concerns, obviously, with prolonged therapy and potentially nephrotoxic ability for it to happen. So looking at some of the studies from the early 2000s, you can see that a lot of these came out looking at a dual therapy. So median duration of therapy in this case was 42 days of the cell wall activation and 2 weeks of the aminoglycoside. It only had a 16% mortality with a 3% chance of relapse. and that mortality was not associated with shortened aminoglycoside course. So this study was really to show that we can give this synergy combination up front and actually limit the amount of overall time we have to give the aminoglycoside. So traditionally with endocarditis, we know that we're giving a prolonged up to 6-week course or beyond 6-week course, and giving the aminoglycoside now, we can limit it to a 2-week course. And then another, one additional study actually took them head-to-head, 2 weeks versus 4 to 6 weeks of Gent in circulation 2013. Even to help with this, the majority of patients did receive once daily aminoglycosides instead of the traditional 3 times daily. And then when you looked at the 1-year event survival, they were comparable. And then when looking at the estimated GFR at discharge, you can see that the 2-week period of aminoglycoside versus the 4 to 6 weeks of it had a significantly lower overall reduction of eGFR. So they had less amount of renal nephrotoxicity. It's just really validated that you could do just 2 weeks of your aminoglycoside if you have to go that route, and it's associated with less nephrotoxicity. So next we'll jump over to 2 beta-lactams, which I know that we always think about that can't ever be the right answer. But if you think about it, when you actually give a beta-lactam and a beta-lactam inhibitor, you're actually giving 2 beta-lactams at once. You just really don't think about it because of the core structures. But to get into AMP and Ceftriaxone, like we discussed previously, we know that Ceftriaxone doesn't have realistic activity, should be the word to use against Enterococcus. It can't be used as a monotherapy agent. But we know that PVP4 and PVP5 are the most important for antibiotic activity. So that's why Enterococcus increases PVP5 when it tries to develop resistance to ampicillin. So looking at our different agents, we know that ampicillin has the most activity, following all the way down the carbapenems. So they have exclusive activity towards 4 and 5, but when you look at cephalosporins, they actually most at 2 and 3. So this doesn't elicitate an actual, kill response or killing effect towards Enterococcus, but it can decrease its cell wall element and cause some significant problems for the organism. So what actually happens is that ampicillin partially saturates PVP4 and 5. So when you have that happen, PVP3 and PVP2 actually compensate to form cell wall synthesis. So we have that, what we end up getting that bacterial static effect. So you don't get that full-on killing effect that you would have liked to see, particularly in a high burden infection. So when you actually add on Ceftriaxone to this, it binds in substrates like we were discussing, the PVP2 and 3. So when you combine those together, you get the partial saturation of 4 and 5 and the total saturation of 2 and 3. So that compensation is actually not able to happen, and so you get a full-on synergistic cidal effect. So how do we know this works? It all does stem from retrospective studies. The first one really being an in vitro study that compared AMP plus Ceftriaxone plus AMP plus Gent, and it looked at reduction of bacterial counts of vegetations in vitro, and it showed that AMP plus Ceftriaxone was as effective as AMP plus an aminoglycoside. Take that further, and same people actually ended up doing an observation open label trial. Very small amount of participants ended up having what really differentiated high level resistance aminoglycoside faecalis versus non-high. And they showed that in the high level resistant Enterococcus, you can use AMP Ceftriaxone in these cases to subsidize for it. So it ended up being a potential possibility. Then Fernandez and colleagues had a bigger observational trial where they compared the 2 specific regimens and showed no difference overall in mortality, but you did see a significant difference in new renal failure, particularly in the aminoglycoside group, the AMP plus Gent. So from this, it was regarded that ampicillin plus Ceftriaxone is as effective regardless of high-level resistance aminoglycoside status with minimal risk of renal failure. So some pros and cons of this. So when using ceftriaxone, you do get less nephrotoxicity. You don't have to have any drug level monitoring. And it's as effective from data that we know. The downside of that is you can get potential increase in C. diff and drug-resistant organisms. And then also you do have the increased risk of beta-lactam related adverse effects. Gent, we know, pro, you can just only have to use it for 2 weeks and do the once daily dosing to have it less nephrotoxicity. But from an overall standpoint, it does still carry that nephrotoxicity and ototoxicity, requires the drug monitoring, and you can have an increase in resistance, which makes the combination ineffective. Because of time, I'm just going to skip over this question. It would be fairly straightforward. And trying to jump into our high dose daptomycin plus the beta-lactam. So why don't we consider combination therapy for daptomycin? So we know with ephasium, delays in appropriate therapy and inappropriate drug exposure, we have a higher increase in morbidity, mortality. And then we do have evidence from an in vitro and some in vivo standpoint that there is reduced efficacy, particularly in isolates with MICs of 3 to 4. And then you can have some undetectable potential mutations that may render your doses at 6 mg per kg inadequate. So what actually started this high dose daptomycin was some previous retrospective studies indicating that you might need higher doses, but then Avery and colleagues in CID got some pooled data from observational studies. They did a PK/PD model to determine the free AUC MIC threshold to predict survival at 30 days and showed that you needed to be greater than this number of AUC of 27.43 comparatively. So this was a survival pharmacodynamic threshold explored in Monte Carlo simulation. So what does that actually extrapolate to? What it extrapolates to is the particular MIC and particular dose you need to give in order to achieve that. So when you really focusing on the higher MICs of 2 to 4, you can see that in both males and females, you need to actually give that higher 10 mg per kg to 12 mg per kg dosing to really achieve those MICs and hit that threshold. So then comes about high dose daptomycin plus the beta-lactam and what does it offer? And then also looking at phosphomycin, because we know previously that data suggests reduced efficacy in these higher MICs. So what does it actually happen when you add on a beta-lactam? Well, we know there's a bunch of robust in vitro data, just like there is with MRSA at this point in time. And studies suggest that really it's about the saturation of several PPPs for the antimicrobial activity that allows this. So once again, it has this saturation that reduces the net positive bacterial surface charge. And so you get the enhanced bacterial cytal effect of daptomycin. So then Avery and colleagues went back again and found some observational studies of patients who received dapto plus an additional agent, which was focusing on beta-lactams, and discovered that through a PK/PD model, that your association between your free AUC and MIC greater than 12.3, so significantly less, offered that survival benefit. So once again, pulling up this table, you can see when you even give dapto at 8 mg per kg at this point in time, along with the beta-lactam, you have a clinically more successful chance of hitting that MIC threshold that's needed. But really, once you get up to MICs of, really once you get like to 2 to 4, you really should still be using 10 mg per kg to 12 mg per kg along with that beta-lactam, particularly in MICs of 3 to 4. So there is some limited clinical data that shows this. It's from Chung and colleagues. They actually have both studies about this and with phosphomycin. From an overall standpoint, you really can see that daptomycin is less than or equal to 2, dapto plus the beta-lactam, you did have a significantly lower mortality. When daptomycins were greater than or equal to 4, there was no survival benefit. So from an overall standpoint, really once you have a daptomycin of 4 or higher, you really should consider just using a different agent and not even trying dual therapy at this point in time. So they were able to conclude that high dose dapto plus the beta-lactam might improve survival, and that this regimen might particularly improve survival when your dapto MIC is 2 or less. So when you do have a VRE infection with or without source control, it would be wise to potentially consider a dapto plus beta-lactam regimen, particularly for ampicillin or ceftriaxone in the cases of activity-wise for killing effect. And then the same group looked at the safety and clinical outcomes of daptomycin plus fosfomycin. They actually have IV fosfomycin where they're able to look at this. Characteristic-wise, you can see they split it into non-survivors and survivors. The majority of patients had a 10 mg per kg dose of dapto, while phospho was at about 16 grams per day. And then when they did their logistic regression, the points of interest to focus on were that your dapto dose offered a improved chance of mortality benefit chances of that. So higher doses made an impact. Things that negatively affected mortality were your pit bacteremia score, your phospho-MIC, and your Charlson comorbidity index. So obviously, the more severe the patient bacteremia, and then having resistance to phosphomycin in this case, led to worse clinical outcomes from an overall standpoint. So pros, you get the enhancement of the dapto's PK/PD, lowering your targets needed. You're able to overcome and suppress some of those undetected resistance. There is a survival benefit, but it's all observational data now. And then for the cons, there is a lack of significant clinical data to support this. This stuff is, you kind of still have some weak recommendations. And there is some potential evidence of increased risk of AKI really extrapolated from the MRSA studies. So in conclusion, dual therapy is obviously going to continue to be an evolving topic. It has robust in vitro data and observational data with the trend in positive clinical data. But really the devil's in the details, I think personally, when you decide when I should move about with combination therapy. And with that, I will take any questions.